perch. Because the sit to stand is going to be something that we're going to bring our patient into high perch. They may not be able to sit to stand from a low surface for a while, right? Like, we're going to be working on things in standing before they can actually do a sit to stand from a normal height. That makes sense? Because we want to get them up and we want to get them the benefits of weight bearing, rotation on their feet, the approximation, the weight shifting, all the things that we know are important from our sitting balance lessons, right? So we're not going to wait to start these things until we can sit to stand from a normal level. So that is kind of a standalone progression. Like, you start in high perch and you do exactly what we did. That is a sit to stand progression. When we start talking about standing the person to do standing balance activities, then we're going to stand them in through the high perch position. So take them up a little bit at a time, but then we're just going to stand them. We're not going to go back down and back up and back down and back up through the sit to stand progression. Does that make sense? Everybody understands that that's a kind of a separate activity? Okay. So, once you bring your patient all the way up into high perch and you bring them away from the table, then at that point we have to establish standing balance before we can do anything else, just like we had to establish sitting balance. So, a lot of times you're going to be hanging here and you bring them up and they may be, their feet are too far forward. So one of the things that you're going to want to do is have them scoot their feet backwards first. So, I don't know, pick a side. This side's my weak side. So you'll have to help them shift weight, because they're not going to want to put weight on the weak side. They don't trust it. It is weird. It doesn't feel right. You know, it feels like lead. It's spastic. It's whatever. It's bad. That this is truly somebody with a bad side. That's the way they're going to feel about this side. That's neurologically not okay. It's not just a broken limb, okay? It's something that's not making connection to the brain correctly, and so therefore it is enemy number one, and we're trying to avoid it at all costs in this person's brain. Whether they understand that's what they're doing or not, they are avoiding it. Even if there's no neglect, they don't want weight over here, especially in standing, because they do not trust it. So one of the biggest things that we have to do as clinicians for standing is just to get them to shift weight over here, because they don't want it, okay? So one of the very first things that we do when we shift them straight forward, we're not really staying there for too long when we're testing to see if they'll take weight, right? When we're just standing them up like we did last time, just pulling them away from the table. So now we're purposely going to see, can we get them there and keep them there? Not just will they take weight. So in order to do that, we're going to have to move the feet back. So in order to do that, you're going to have to block knee. If your patient cannot hold weight against gravity, then that knee has to be blocked. Yes, everybody hears that? Mm-hmm. Not just close. If something happens, it must be blocked. When you shift weight onto that side, anytime you shift weight on that side, if your patient is not at least a 3, that will be considered a safety fail. Okay? All right. So, in this position, you're going to block their knee and physically use hands on pelvis to shift weight over towards you, because you're going to be on the weak side. Okay? And then you're going to ask them to move their good foot back, because now it can move. Because we can't move this foot if they won't take the weight off of it. So we got to get them to move this foot back first. And then as soon as you let go, they're going to come back over here. You really don't normally have to facilitate that weight shift. Weight shifting in standing with neuro patients is key. That is how you facilitate most things. And you probably saw that a little bit in the peds the other day, right? So and neuro follows the pediatric developments. So they'll come back over here, and then is there a need to keep this knee locked at that point? Do they have any weight over here now? Okay, so is this the danger of falling? No. So you don't necessarily, you're not gonna step away or go anywhere, but we don't have to be so focused on keeping the knee under the patient at this point. These are things that are difficult. When do I block, when do I not block? Okay? So then depending on, if your patient has, depending on what your manual muscle testing is, how much you have to help them, hopefully active assistive, back to here. So you want the feet about shoulder width apart and even. Okay? Then you're going to reblock before you shift the weight back equally over both legs. Make sense? Not all the way over here, not all the way back over here. When both feet are set, you should be 50-50. And then you're going to stand them back up again with the intention of seeing if they can hold static standing balance. Okay? And this is just kind of an endurance thing. It's just getting used to being on our feet thing. If the best thing for them to do is to just stand here. There's not a whole lot. If we don't have the ability to go dynamic at this point, there's not a lot to, the best thing they can do is stand. Because what are they working right here? Everything. Everything. So, and we don't want to give them an assistive device yet at this point. If they're uncomfortable, they can hang on with their good arm. Just make sure that that's not having them lean to that side. Okay, so if they feel uncomfortable, even with you holding, just make sure that the arm that's hanging on isn't causing a lean in one direction or the other, because we want equal weight at this point, because we're trying to get static balance, which would be 50-50. That makes sense? So this may be another case where the mirror would be nice, because if they're constantly leaning to one side or the other and they really do not even want 50% on this side, then it may be that you need the mirror to show them that they're offsetting, or that they don't, oh no, I've got plenty of weight through that leg now, because I could pick it up right now and fling it halfway across the room because there's no weight on it. So, the mirror, that visual feedback might work for that patient again to get them, it's not that their midline is shifted at that point. They could be. This is okay, what's going on? Is it that they don't like this leg, so they're leaning this way because they just don't trust this leg? Is their midline truly shifted? Do they have left neglect? We got to go through a list and rule out what's going on. Because a lot of them do not like to put weight on that side. If it feels dead, then they consider it is dead and it's unusable. Okay? So we got to figure out what's going on here. So put the mirror in front of them to help when you're doing like static stuff. But there's the static stuff is just going to kind of be lean and rest when they get tired, and then come back up with equal weight. So they're using all of the muscles, all the anti-gravity muscles. They're using all the muscles that are repositioning them if they have any sway. Yes. So there's not a lot of treatment options when we're working on static and standing, like we had a few. Now, if their posture is bad, you know, you're gonna wanna correct that, but in a real patient, for these purposes, just standing tall is gonna be what we're gonna work and focus on to gain that static. We want endurance of the muscles, we want the full upright posture. So questions about that? Okay, so then once we have established the static sitting balance, or static standing balance, so we have static. We're going to do a pivot turn. Where so you are going to have your patient here in a static stance. Good, we're ready to move on. You're going to have them place that arm out this way, okay? So, because we're going to be turning, if this is my strong leg, we're going to be turning that way. If this is my strong leg, we're going to be turning that way. Okay? So, we already said my left was my weak side. So, I'm going to have my patient, I'm going to have the table, if the table's at their ischials, it should be about the right height, but you may have to adjust it. So, no, there's no like specific, perfect, you know, this is exactly where it needs to go type thing. You just have to, you may have to readjust it. So what you wanted at the height to where they can lean into it with their good side. Okay? Because they're going to have to be able to weight bear on this arm and this leg. So the first piece, you're going to block, have them weight shift towards you so they can turn the good foot out into external rotation. And then you're going to have them lean in. And again, now we don't have to block the knee, right? Because we're not responsible for anything on this leg. You're going to kind of follow around and scoop the patient. So now we've done just a little pivot turn, block the knee, let them reset this foot, and we are fully turned in this direction for our activities. Okay? Simple enough. We're learning when to block the knee, when not to block the knee. The rule of thumb is if there's weight on it, you must block it.
Should we put a chair behind them just in case they
No.
fall back? No?
No.
Okay.
No safety. No safety nets.
Okay.
There's no reason. There's no reason to have one. It's going to be in your way. It's going to be in your patient's way. It's going to be more of a hazard. Because if you're doing everything the way that you need to do it, you don't need it. Okay? So you're going to do that pivot turn. And then we will start with, oh, we have to do that pivot turn twice. Sorry. So the first activity, you'll do the pivot turn times 2 so that your patient will actually wind up facing. So block, come over here, turn this foot out, lean in. You're gonna help scoop the leg. They can do what they can, but depending on the manual muscle testing in this leg as to how much they can move it. Block again, have them reset the good leg. Okay, we all set? Okay, good. I'm gonna block this one again. I'm gonna have them weight the affected leg. Again, turn out into external rotation. The good leg, lean in to the table, weight bear on the table through the upper extremity, through the lower extremity. You're gonna help scoop the leg around and here. So now we've just done that same exact pivot turn twice to get them facing the table, okay? Okay, so our first activity, we're gonna do this, and then you're gonna do lateral weight shifting. So, you want to know, can my patient weight shift on it and over to the side that they don't like? So, at first, we're gonna go good side, middle, bad side, middle. So we'll stop in the middle to start with, to give them a sense of midline and standing, and a neutral pelvis, right? And then, once you see that they can handle that, you will try to go through. And again, that knee has to stay blocked when it's being loaded or when it's loaded. Because particularly when it's being loaded, it can buckle at any time. But when it's off the floor, when you're shifting this direction, and when you come back, that's when it's going to be the absolute most vulnerable. Once you're here and it's locked out, as long as it's not a 1 out of 5, you have a slight chance that it might stay locked for a couple seconds to get your knee back in there. But if you're not in place as it comes over, forget about it. Because as it starts to come back over, if you don't have that knee in the right position, that leg can't take weight. So, we'll start by stopping in the middle, and then you'll progress to a nice, free-flowing lateral weight shift. So you have to adjust yourself accordingly. So that's going to be our first activity. Obviously, with the table in front of us, they have the ability to use the good arm. If we can get the spastic arm, or the arm that is, somewhat usable, we're going to encourage them. We're going to place it there before we begin. We're going to encourage them to use it as they can. Like I said, when we begin standing activities, we no longer have enough hands to focus solely on the upper extremity, because we've got to focus on the hips, the pelvis, we've got to focus on the knee that might give way to us, which is being done with our knee, right? But if the knee gives out, or if the knee gives out on that side, and then what's going to go next? The hip. So we're gonna have to have a hand to bring the body back up as well, and then push the hip in while the knee's being managed by our knee. So both hands are definitely gonna be taken up. So we don't have the ability to have enough hands to manage this upper extremity the way we did in sitting. So we do have to make sure it's safe, which I said if it was flaccid, we would have it in a sling at this point. If it does have some spasticity, and you would still address that initially, if it goes back to being spastic, it goes back to being spastic. So if the tone pattern goes back to where it was, it just does that. Because if we're standing and the tone pattern goes back in, is that helpful to me? Is that leg gonna buckle if it's locked in tone? No. So I'm not really caring at that point, because I'm just trying to get them to move. Do I want that to stick around forever? No. However, for right now, we'll work with it. And then the hope is, when I weight bear, what should happen? The weight bearing itself should also cause it to calm down a little bit in the lower extremity, maybe not in the upper extremity, but in the lower extremity it should. So there's a lot at play here, but just kind of try to remember all the things that affect the spasticity, not just the trunk rotations in the arms. And if the leg is locked up and I can't, it's not even touching the floor, it's so bad, then I would do some trunk rotations and standing to see if I could get it down to where I could get weight bearing on it. So that would be how you would address that in a real person. That's not going to be a scenario in here. We've kind of, I don't want to say been there, done that, but you guys have pretty much embraced that part of it. And but if you had that happen, that's kind of how you would address that. So, but we need that patient, over this table. So worst case scenario, you can throw them forward and lower it and roll them, right? So this is a very safe place to work with patients. This is a high-low table. And it's also nice about it is that as you lower the bed down too, they can kind of sit as it goes down. You just have a lot of options, and it's we can do this in the parallel bars. You can do all of these things in the parallel bars as well. The clinician just has more room here. When we start putting ourselves where we need to be for these activities versus putting ourselves where we need to be, especially in ours, but in any set of parallel bars, we have a lot more room to work right here, which is why this is where I choose to teach you. But you can just modify everything and use it in the parallel bars as well, if you didn't have one of these available to use and you needed to treat a patient that needed these activities. And then a lot of times the parallel bars don't come up this tall. You wouldn't use high perch, obviously, in parallel bars. You just have to stand them up and start the activities. But a lot of times you can't put the bar up as far as you can put the mat table up. So we're going to start that, and so we're going to do lateral weight shiftings first. After we've established static, lateral weight shiftings first, and then I feel like I'm missing a piece. Oh, I think we're sure that they can do that, then you're going to do some reaching. So this will technically be this table, and you have them in a good position, then you could, again, we're only going to work with the upper extremity that is unaffected. So if this one's in a sling, if this one's able to be on the bed, great, whichever one. And then you're either going to have, you're gonna be, over on this side, blocking the knee over here. So you can either have them, so you're either going to have them, so you would be on this side. You can either like put your hand out here for them to like try to reach and touch, again, just inside the base of support. You could have them reach for something on the table. So if you wanted to have like the cones set up on the table, just like you did for the sitting. So this is gonna be an in the box activity, in standing.
We're blocking the knee that whole time while managing that as well?
While managing what?
Like if we're doing like the, oh, tap my hand here, we're also still down there blocking the knee.
Yeah, I mean, you'll just be positioned, you'll just like, that's just where you'll stand.
Okay.
Yeah, you can stand, pop up here a second. Just face out even though you would be facing the table. If this is your bad leg, you're gonna be shoulder width apart, right? I'm just gonna get right here. Now, try your hardest to buckle your knee on that side. Push, 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 push. And I'm not exerting any force. That's just where my foot's placed. And it's not hurting your knee at all, right?
No, it's not
Because
even on
our
my knee.
knee, yeah, our knees aren't touching. So, you just put yourself here.
Okay.
And then reach, reach, reach. So for inside the box, it's fairly easy. Right?
Yeah.
Okay. So, or you can use the table if you don't feel comfortable like wanting to reach around, or you think, gosh, my balance is not that great. So maybe I don't want to be like flinging my arm around making them. And for certain patients, if they're really pushing on you, you know, like if that knee's really giving you fits, maybe you do want to set something up on the table instead, because you've got this entire table to work with. It's already built in. So you can do that. So you're just gonna do, you're gonna do reaching inside the box. So whatever that looks like for you, and then you're gonna do simple and complex. So you'll technically do 2 inside the box for standing, because you're always gonna do this activity first. That's just kind of to test the waters, but it still is an inside the box activity. It's also a midline orientation activity, so, but this is always gonna be your first activity.
The middle stop was middle, good leg, middle, bad leg.
You can, I mean,
Or
you can
either
start
way.
either, it doesn't matter which side you go to first. It's
Stop
just
in
that
the
you
middle.
are doing the lateral weight shifts and that you are making the middle pronounced. But you're not telling them verbally, you are guiding them with your facilitations. And those are gonna be your pelvic, your like your crusts. So then you're gonna do reaching in the box, something simple, something complex. And then we are going to go, we're going to do reaching outside the box. Now, what that looks like is we're here. We're gonna have to turn back to the side in order to get them to, because how are they gonna reach out of their base of support when this is in the way? All right, so we're gonna have to do kind of the reverse pivot. So if this is my weak leg, I'm gonna be the therapist will be blocking it, have me shift my weight over here so I can kind of internally rotate this foot, lean in, put weight over here. Then as the therapist, I'm gonna help this leg around. Now, because we don't have as much internal rotation as we have external rotation, sometimes this is a twofer. Sometimes you gotta do it twice because you can't get quite turned around all the way you can, because most people just have loads of external rotation, right? So we can just really whip that foot out there and do it all in one turn. But a lot of times you may have to do this one twice. So then block the knee again, shift the weight, position the foot, lean in, and then you're gonna help position that foot exactly where you want it, for it to be able to, for you to lock it and position yourself in order for it to take weight. Again, you wanna establish the 50% before you begin the activity. So now we're going to do our outside the box, in this side position where the good leg toward the table, the good hand toward the table. Okay? So, then you're going to do reaching. And you can set up the table, so you can have them reaching a little bit to this side. You're gonna be to this side, so not gonna be anything full on out this way, because you're not gonna be able to do that, because you're not gonna be able to move away from them far enough to allow them to go out this way. So just try to go left and anterior as it feels safe. But you can go front, and then you can use this entire table. With all the things that you've already learned for sitting balance. Just remember that when they go over here and they come back, that knee has to be taken care of by you, the therapist. Unless it's a 3 or above. So, and then you'll do simple and complex. Again, it can be the same types of things. It can be different colored cones. It can be different objects. It can be, you can lay out a hodgepodge of things and say, okay, there's a bunch of stuff laying around. I want you to grab everything that you could eat and then pitch it in that bucket over there. And so, or you could have a lot of departments have bean bags. They'll have bean bags and a mop bucket. And so you could, like, they usually have multicolored bean bags. So you might lay out red and green and blue and say, first time, I want you to grab all the red ones and then throw them in the bucket. You may have the bucket there to get some of that forward left that you can't really get good because you can't move from this position right here. So it would give you a little bit of kind of uncontrolled and, weight shifting forward. Then you could say, okay, now all the blue. And then, they would grab them from wherever, and then they'd have to come over here and weight shift and try to throw them into the bucket over there. So that would be a great activity in standing. It's something we do frequently. So it's all the same premise. Can you use exactly the same activities that you did in sitting? Will they apply? Maybe, maybe not. But it's very much the same type of flow. It's the same type of goals. What are we looking for? We're looking for weight bearing. We're looking for them to get out there and be able to come back. And if not, then how can we help that, right? So because this is in prep for doing stance leg activities and then swing leg activities so that we can go into gait. So that's what these exercises are feeding into. Make sense? So we'll do the outside and then we'll do simple and complex. But the feet do not move here. I mean, the one foot may come off the floor a little bit, obviously, as you're reaching, but I shouldn't see you like doing anything with the feet. That's later. So they pretty much should be planted. Again, that foot may come up off the floor when they're reaching, because if they're reaching outside the box, that may happen. But you're not cueing them to do anything with their feet yet. Okay? And still, it's the unaffected arm that's doing the workhorse of the work. Questions? Seem fairly straightforward. I think just learning to block the knee is the big part here. And then again, take into consideration, what's this gonna look like with an ataxic person? How are you gonna counteract that when this leg might be a 4 out of 5? However, when you put all of those uncoordinated, unpredictable movements in there, how are you going to tailor that treatment, and how are you going to guard that person then? If they are still a pusher and we're relying on the table, problem solve that one. What are you going to do? If they have neglect and you have to be over here because you don't have any choice because the leg is going to go ooh if you're not over here, problem solve that one. So on top of doing these, you have to apply it to each one of your diagnoses just like you did for the sitting balance. So commence.